Good morning. I am Dr. Saurabh Piparsania. In continuation of lecture series on newborn, today I will be talking on respiratory distress in newborn. It is a very important topic because respiratory distress in newborn is a common occurrence in an ICU, and it can be a serious neonatal emergency if not handled properly. I'll cover the topic under the following head. What is respiratory distress in newborn? What are the different causes of respiratory distress? Then case-based discussion on common causes of respiratory distress like respiratory distress syndrome, meconium aspiration syndrome, transient tachypnea of newborn, cardiac causes of respiratory distress, and common surgical condition that may present with respiratory distress in newborn. So what is respiratory distress? It is suspected in newborn when respiratory rate is more than 60 breaths per minute in a resting quiet baby. Normally, the respiratory rate in newborn ranges from 40 to 60 breaths per minute, and whenever the respiratory rate is more than 60, it is known as tachypnea. Respiratory distress is often associated with subcostal or intercostal retraction, nasal flaring, grunting, dullness and letharginess, cyanosis, and inability of the newborn to maintain SpO2 on room air. Respiratory distress in the newborn is the commonest problem causing mortality and morbidity. Early recognition and prompt treatment is essential to improve the outcome of babies with respiratory distress. The causes of respiratory distress can be classified as pulmonary causes and non-pulmonary causes. The common pulmonary causes are respiratory distress syndrome or hyaline membrane disease. In this, the newborn develops respiratory distress within first 6 hours of life, and it is commonly seen in preterm babies. Second is meconium aspiration syndrome. Again, the newborn present with respiratory distress within first few hours of life, and it is commonly seen in preterm, term, postpartum, and IUGR baby who have experienced fetal distress during intrauterine period. Third is pneumonia. It can occur at any age. It is commonly associated with pervaginal leaking of more than 24 hours, pervaginal bleeding, premature rupture of membrane, history of fever in the mother, and chorioamnionitis. Presence of these features may point towards the presence of congenital pneumonia in a newborn with respiratory distress. Transient tachypnea of newborn is another entity that is commonly seen in newborn who present with respiratory distress. It has its onset within first few hours of life, and one of the important causes of transient tachypnea of newborn is poorly timed C-section. PPHN is another important cause of respiratory distress. It can present at any age, and it is often seen with cyanosis and severe form of respiratory distress in the newborn. Pneumothorax can occur at any age, and it is commonly seen in newborn who has undergone positive pressure ventilation at the time of birth or thereafter. Congenital malformation of the lung can also present with respiratory distress, and the common causes are tracheoesophageal fistula, congenital diaphragmatic hernia, congenital cystic adenomatoid malformation of the lungs. The non-pulmonary causes of respiratory distress include cardiac causes, which are congenital heart disease and congestive cardiac failure. Metabolic causes can also present with respiratory distress in newborn. The common causes are hypothermia, hypoglycemia, metabolic acidosis because of sepsis, dehydration, or asphyxia. Central nervous system causes that includes perinatal asphyxia, intraventricular hemorrhage, and cerebral edema. Certain chest wall problem can also present with respiratory distress in newborn, and these are thoracic dystrophy. So this is all about the common causes of respiratory distress that can be seen in newborn. Now coming to the first case, a primary mother gives birth to 32 weeks preterm baby vaginally by vertex presentation with birth weight of 1.5 kg. Apgar score was 5 and 9. Baby developed respiratory distress 4 hours after birth. X-ray shows the following features. So, what could be the most probable diagnosis? Can it be a case of respiratory distress syndrome, or meconium aspiration, or transient tachypnea of newborn, or congenital pneumonia, or congenital diaphragmatic hernia, or pneumothorax? What is it? Now, coming back to the question and try to solve the puzzle. Baby is born to a primary mother at 32 weeks of gestation. That is, baby is born preterm with birth weight of 1.5 kg. That is, birth weight of the baby is also very low as compared to the normal birth weight babies. Though the Apgar score was okay, it was 5 and 9, and onset of respiratory distress was seen within first 6 hours of life. So, onset of respiratory distress within first 6 hours of life, who is born preterm with low birth weight, and X-ray is showing reticogranular pattern. So most probably the cause of respiratory distress in this baby is respiratory distress syndrome or hyaline membrane disease. Now what is it? Respiratory distress syndrome or hyaline membrane disease is commonly seen in preterm babies who are born before 34 weeks of completed gestation. This is the commonest cause of respiratory distress in a preterm baby. Apart from prematurity, other important causes of hyaline membrane disease are birth asphyxia, metabolic acidosis, maternal diabetes, and C-section. So one of the most important causes prematurity. The incidence of the respiratory distress syndrome is inversely related to the gestational age of the newborn. As the gestational age of the newborn decreases, the chances of the respiratory distress syndrome or hyaline membrane disease goes on increasing. Now, what causes respiratory distress syndrome? We know that surfactant is a lipoprotein which is produced by the type 2 pneumocytes of the lungs. The production of surfactant usually begins at around 20 weeks of gestation, peaks at around 35 to 36 weeks of gestation. Therefore, it means that the surfactant reaches the mature level only at around 35 to 36 weeks of gestation. So, any baby who is born before 35 completed weeks of gestation can develop respiratory distress syndrome. Now, what is the function of surfactant? Surfactant helps in reducing the surface tension in the alveoli from the outside. If the surfactant is less or absent, surface tension in the alveoli increases and alveoli tend to collapse during expiration. So it causes more negative pressure is required during inspiration to keep the alveoli patent. Inability to maintain the alveoli patency, inadequate oxygenation and increased work of breathing occurs, which leads to hypoxia and acidosis, which causes pulmonary vasoconstriction and right to left shunt across the foramen ovale, which further worsens the hypoxemia and respiratory failure finally sets in. This causes ischemic damage to the alveoli, and because of the damage to the alveoli, the protein that is present inside the alveoli transduates into the alveoli and it gives a hyaline membrane-like appearance. So the basic cause of respiratory distress syndrome is prematurity because of the deficiency of the protein, which is known as surfactant. Clinical features of RDS. Onset of RDS is seen within first 6 hours of life. It commonly presents with signs of the respiratory distress like tachypnea, that is respiratory rate of more than 60 breaths per minute, intercostal and subcostal retractions, grunting, cyanosis, decreased air entry, and inability of the baby to maintain SpO2 on room air. Respiratory failure may occur if the newborn is not managed timely. Diagnosis of respiratory distress syndrome is mostly a clinical diagnosis, but prenatal diagnosis can be made by measuring lecithin sphingomyelin ratio in amniotic fluid. If LS ratio is more than 2, it indicates pulmonary maturity. And if it is less than 2, it indicates deficiency of the surfactant. Second test that can help in making prenatal diagnosis of RDS is shake test. In this, gastric or amniotic fluid is mixed with alcohol solution and is shaken for 15 seconds. The solution is allowed to settle, and if bubbles are formed, it means surfactant is adequate. And if the bubbles are not formed on shaking the tubes, then it means that the newborn has deficiency of surfactant. Various other tests are also available for making the diagnosis of RDS antenatally, but we will not discuss those topics uh, at present. Investigation data to be done in a child with respiratory distress syndrome are septic screen. It includes CBC, CRP, absolute neutrophil count, micro ESR, blood culture, measurement of the serum calcium level is to be done. X-ray chest, it is done only after 6 hours of birth. Serum electrolyte levels, blood urea nitrogen, serum creatinine, and other investigation as and when needed. Diagnosis of RDS is mostly clinical, and X-ray shows characteristic pattern, which is known as reticulogranular pattern or ground glass opacity or white out lung. These are the three common patterns which is seen in a newborn with respiratory distress syndrome. Reticulogranular pattern, ground glass opacity, and white out lung. Now, how do we treat a newborn with respiratory distress syndrome? It has supportive treatment and specific treatment. Supportive treatment includes maintenance of thermoneutral environment. You have to nurse this baby in a tertiary NICU under radiant warmer. Ensure the patency of airway. Do oropharyngeal or nasopharyngeal suctioning. Support breathing with oxygenation either by nasal cannula, hood, CPAP machine, or by mechanical ventilation. You have to assess and maintain circulation via intravenous fluid, use of inotropes, or bolus of the crystalloid or colloid solution. You have to manage electrolyte balance in case of dyselectrolytemia. To start with, give dextrose solution for the first 2 days and add electrolyte only after 48 hours of birth, after the initial diuresis has been done. Avoid sepsis, so minimize handling of such baby. Use all the aseptic precautions, including proper hand washing by the healthcare workers. And you have to ensure that the baby receives adequate amount of energy or calories. If baby is not going to be on significant enteral feeds for coming 3 to 5 days, start intravenous fluid with total parenteral nutrition. You can also initiate trophic feeds at the rate of 1 to 2 ml per kg per day. Then the specific management, it includes surfactant replacement therapy, which can be prophylactic, selective, and early rescue therapy, and ensure is the technique that is commonly recommended nowadays for the delivery of the surfactant. It stands for intubation, surfactant administration, and extubation of the newborn. Complication can occur in newborn experiencing RDS, and these are during recovery phase, CCF may occur. Apneic attacks are very common in newborn with respiratory distress syndrome because of prematurity. Third, interventricular hemorrhages can occur. DIC can occur, which may lead to bleeding inside the brain or lung. Prolonged ventilation can cause Ehrlich syndrome, retinopathy of prematurity, and bronchopulmonary dysplasia. These are the common complications that can be encountered in a child with respiratory distress syndrome. So, is there any means by which we can present respiratory distress syndrome? Yes, definitely. If we can suppress premature labor, then respiratory distress syndrome can be avoided. If labor is unavoidable, that is, baby is expected to be delivered at 24 to 34 weeks of gestation, intramuscular administration of betamethasone 12 milligram given in 2 doses at 24 hours interval is sufficient, or administration of dexamethasone intramuscularly 6 milligram 4 doses every 12 hours is sufficient to ensure slight or adequate pulmonary maturity in preterm babies. So this was all about respiratory distress syndrome. Now coming to the case 2. A full-term baby is born to a primary mother with meconium stained liquor. Baby cried after resuscitation. Birth weight was 3.2 kg. Baby was kept in NICU for observation. Respiratory distress increases and worsens in next 24 hours. So what is the most probable diagnosis? RDS, MAS, transient tachypnea of newborn, congenital pneumonia, congenital diaphragmatic hernia, or pneumothorax. Now we will try to reduce the diagnosis from the question itself. Baby is born at full-term gestation with meconium stained liquor, and baby cried only after resuscitation. That is, baby was limp at the time of birth and required resuscitation. Birth weight was okay, it was 3.2 kg, and respiratory distress worsens in the next 24 hours. So a full-term baby born with meconium stained amniotic fluid with respiratory distress. So the most likely cause is meconium aspiration syndrome. Now, what is meconium aspiration syndrome? Baby, the first stool passed by the baby is known as meconium. Thin meconium can cause pneumonitis, and thick meconium can cause blockage of respiratory tract and ultimately may lead to respiratory failure. MAS is commonly seen in postpartum baby and IUGR baby and term neonates who have fetal distress during intrauterine life. Babies develop respiratory distress in first few hours of life, and the worsening of the clinical condition is seen in the next 24 hours of birth. What are the clinical features? Again, tachypnea, that is respiratory rate of more than 60 per minute, cyanosis, intercostal subcostal retractions, grunting, and labored breathing. Child is often unable to maintain SpO2 on room air. Apneic spells can occur. Dyselectrolytemia is common, and there is staining of the umbilical cord in babies who have thick meconium at the time of birth. X-ray in such a baby will show bilateral heterogeneous opacities, areas of hyperexpansion, atelectasis, ear leaks, and respiratory failure. So, how do we treat a newborn with meconium aspiration syndrome? The delivery room management includes that the delivery should be attended by a pediatrician or a neonatologist or a person who is skilled in neonatal resuscitation, so that whenever a baby who is born limp can be handled immediately. For a baby who is born with meconium aspiration syndrome, timely and appropriate positive pressure ventilation helps in improving the chances of survival. And if skilled person is available, intubation for positive pressure ventilation is also very helpful. After initial resuscitation, baby is shifted to the NICU and is nursed under thermonuclear environment, preferably as the baby has undergone birth asphyxia or perinatal asphyxia. Therapeutic hypothermia is often initiated, which should be done within first 6 hours of life and continue till 48 hours of birth. Circulation is managed with intravenous fluids or anode and inotropes. Oxygenation is managed with oxygen by hood, nasal prong, CPAP machine, or by ventilatory support. Antibiotic, though, have no role in the management of child with meconium aspiration syndrome, but they are often started in view of the possible secondary sepsis. As PPHN is a common phenomenon encountered in a newborn with meconium aspiration syndrome, so you have to suspect and treat PPHN as early as possible if it is present. Consider inotropic agent in cases of shock. Start with catecholamines like dopamine, dobutamine, and you can also add adrenaline and noradrenaline and milrinone depending on the clinical improvement following each drug. Seizures are commonly seen in such babies, so it has to be treated with as per the protocols for the management of seizures. And feeding are started only when the child is hemodynamically stable. You can start trophy feed as soon as following birth because it helps in improving the survival of babies. So this was all about mesodermal aspiration syndrome. Now coming to the third case, a full-term baby is born to a primary mother by LCS with birth weight of 2.8 kg. Baby carried immediately after birth. Upgar score was 6 and 9. Baby developed respiratory distress 2 hours after birth, and X-ray done after 6 hours shows this picture. So what is the most probable diagnosis in this case? RDS, MAS, transient tachypnea of newborn, congenital pneumonia, pneumothorax, or the congenital diaphragmatic hernia. Now rereading the question, a full-term baby is born by LECS with normal birth weight with normal cry. Upgar score was also very good, but the child had respiratory distress. So what could be the cause? Can it be a case of transient tachypnea of newborn or congenital pneumonia or pneumothorax or congenital diaphragmatic hernia? Most likely it is a case of transient tachypnea of newborn. Now coming to TTNB, it is a benign self-limiting disorder. It is also known as wet lung. It usually seen in term baby or near term baby in whom the LACS was done without precipitous labor, and poorly timed C-section is another important cause of transient tachypnea of newborn. It is due to the delayed clearance of the fetal lung fluid and because of the change in the feto-maternal hormonal milieu, which leads to defective clearance of the fetal lung fluid. So it is often a diagnosis of exclusion. When other diagnoses have been excluded, the diagnosis of transient tachypnea of newborn is made on the basis of the above mentioned clinical criteria. Again, the treatment is patient is nursed in a thermoneutral environment in an ICU. You have to maintain temperature. You have to maintain airway by doing oropharyngeal or nasopharyngeal suctioning. Support breathing with oxygen via hood, nasal prongs, CPAP machine, or mechanical ventilation, whichever therapy is suitable. You have to start. You have to support circulation by giving intravenous fluid. Nutrition is supported by giving orogastric feed or nasogastric feed, depending on the clinical condition of the newborn. Most of these baby recover nicely within 24 to 72 hours of birth, and sometimes recovery may take more time. That is, up to 7 days may be required for a baby to recover completely. Case 4. A full-term baby is born to a primary mother by LACS with birth weight of 2.8 kg. Baby carried immediately after birth. Upgrade score was 6 and 9. There is history of PV leaking for more than 24 hours with fever and foul-smelling liquor. Baby developed respiratory distress after birth, and X-ray is showing this picture. So what could be the cause? RDS, MAS, TTNB, congenital pneumonia, pneumothorax, or congenital diaphragmatic hernia. As RDS common in preterm baby, in mucociliary aspiration syndrome, history of muconemia is seen. So these two conditions are ruled out. In transient tachypnea of newborn, it is a possibility, but the presence of history of PV leaking for more than 24 hours, foul-smelling liquor, and maternal fever points towards congenital pneumonia as the most likely diagnosis in this case. Now coming to the congenital pneumonia, the diagnosis of congenital pneumonia is made on the basis of the exclusion of other common conditions that may present with respiratory distress in newborn, along with the history of following things, that is history of PV leaking of more than 18 to 24 hours in mother, history of fever in the mother, history of respiratory distress with grunting, cyanosis, and features suggestive of sepsis in the newborn. On X-ray, patchy pneumonitis like picture is seen, and septic skin is done, which includes CBC, CRP, micro ESR, absolute neutrophil count, and blood culture, along with lumbar puncture if required. And treatment is again oxygen therapy to support breathing, nursing of the child in a thermoneutral environment by placing the baby under radiant warmer. Intravenous fluids are started. Antibiotics are mainstay of treatment of congenital pneumonia. Preferred antibiotics are third generation cephalosporin or piperacillin plus tazobactam, or antibiotics are changed according to the culture sensitivity reports. The antibiotic policy changes from nursery to nursery, depending on their microbiological flora present in the NICU. The common cardiac causes of respiratory distress in newborn are congenital heart disease like drug-dependent region. PDA is the common cause of CCF and respiratory distress in newborn. PPHN, that is persistent pulmonary hypertension of the newborn, is another important cause of respiratory distress in newborn. Treatment is mostly palliative in the form of oxygen therapy, inotropic agents, prostaglandin infusion, and treatment of CCF. In case of PDA, you can start ibuprofen or indomethacin, and definitive management of cardiac causes are corrective cardiac surgeries. The common surgical causes of respiratory distress are tracheoesophageal fistula. Second is congenital diaphragmatic hernia, choanal atresia, congenital cystic adenomatous malformation of the lung, pneumothorax, and treatment is surgical management. Congenital diaphragmatic hernia is diagnosed on the basis of the appearance of the newborn baby. This baby will have respiratory distress soon after the birth, and they have scaphoid abdomen. On insertion of the nasogastric tube and pushing air into the stomach, you can hear these oxygen sounds in the lung fields. So it is pointed towards the diaphragmatic hernia, and it can be diagnosed antenatally as well by target scanning. In choanal atresia, the pediatrician will not be able to pass nasogastric tube or the red rubber catheter through the nostrils. In congenital cystic adenomatous malformation of the lung, the child will have severe respiratory distress soon after birth, and on doing X-ray, you can see cystic air spaces in the lung fields. And in pneumothorax, you will often get a history of positive pressure ventilation being given to the newborn, and air bronchogram can be visualized. Now coming to the case 5, a full-term baby is born to a primary mother by LACS with birth weight of 2.8 kg. Baby did not cry after birth. Baby required bag and mask ventilation. Apgar score was 3 and 9. Baby developed respiratory distress after birth. Air entry was decreased on the right side with signs of poor perfusion. This is the X-ray. You can see very well around the lower border of the right lung, there is dark air space. So what is the most probable diagnosis? It is pneumothorax. This is an X-ray in a full-term baby who is born to a primary mother by LACS with birth weight of 2.8 kg. Baby had respiratory distress at birth. On examination, abdomen was scaphoid. Heart sounds were shifted and heard on the left side, and auscultation of the chest revealed gurgling sound with signs of poor perfusion. Here in this X-ray, you can visualize that the stomach is herniated and has entered the pleural cavity. So it is a case of congenital diaphragmatic hernia. Thank you. So one of the most important take-home message is, as soon as you get the child or a newborn with respiratory distress, try to figure out the common causes of respiratory distress based on the gestational age of the newborn, timing of the onset of the respiratory distress, presence of any complication in the mother antenatally or at the time of birth or in the postpartum period, because all these points will help you in determining the diagnosis of respiratory distress in the newborn. And as soon as the baby is born with respiratory distress, start treatment without any delay. Shift the baby to level 3 NICU, which is fully equipped. Oxygen therapy is the mainstay of management in treating a child with respiratory distress, along with other intervention like maintenance of the thermoneutral environment, patency of the airway, maintenance of the circulatory system, and judicious use of antibiotic is to be done. And stepping up and stepping down of the antibiotic is done based on the cultural sensitivity report. Thank you.